All right, so today we're going to be looking at chapter 4. We'll be talking about pain, and some of the things that we will discuss are some of the causes of pain. We'll describe the pain pathway. We'll talk a little bit about the gate control theory of pain. That's pretty fascinating stuff. We'll discuss about phantom pain and what is referred pain, radiating pain. We'll compare acute to chronic pain. We've seen this quite a bit, right? Acute versus chronic, acute versus chronic. So now we're going to be talking about it in relationship to pain. We'll talk about headaches and then a little bit about pain management. So, what exactly is pain? What is it, right? It's an unpleasant sensation, it's discomfort that's caused by the stimulation of pain receptors, right? And one of the big common pain receptors are referred to as nociceptors. Noci comes from noxious or obnoxious, right? A pain. Pain is also the body's defense mechanism, right? It lets us know, it makes us aware that there's an underlying problem. I mean, isn't it amazing that you can put your finger on something hot, you can feel that it's hot, and automatically your hand withdraws from the stimulus of pain, that heat. You didn't have to think about it, it happened automatically. I mean, imagine your finger was on a burning stove and you didn't feel pain, but you had to wait long enough to smell burning flesh, and then your head would turn and go, you'd sniff and go, what is that smell? You would see smoke coming from the tip of your finger, at which point you would move it away, look at it, and see all the epidermis being burned, and the dermis, and all the connective tissue and muscle, and perhaps right down to the bone. That would be a bummer, right? So, pain is a warning sign. We need to have that. It's a pretty complex mechanism. Many are still not totally understood, but that which we do understand will be conveyed to you in this lecture. In terms of pain, there are many subjective scales that are used because remember, pain is subjective. So, how do we try and quantify and objectify something that a patient is trying to convey? So we do have these pain scales that have been developed. And here's an example of one. We call it a visual pain analog scale. And, most of you have been asked at least once in your life, how does it feel on a scale of 1 to 10? And I don't like to ask my patients, how do you feel on a scale of 1 to 10? I need to set up a little bit of framework. So when my patient does come in with pain, I usually start with, hi, Mrs. Smith. Mrs. Smith, it says here you have pain in your shoulder or pain in your back. Let's start with this question. What is the worst pain you've ever experienced in your life? Now, if they say the pain they're in right now, then that's the pain they're in right now, right? That's the worst. But most of them do have a reference point of something other. The woman may say, Mrs. Smith may say, the worst pain was delivery when I was in labor. And I'll say, okay, so would you say that that was your 10, your worst type of pain? Yes. Okay. So how does this discomfort compare to that, right? So if that's the 10, they may say, oh, this is an 11 or a 12 if it's definitely worse, or they'll say, all right, this is like a 6 or 7, right? You can also then use this visual analog scale. So they're looking at the faces of perhaps how they feel. All right, and then I like to take it a little bit further. So, what is your pain right now, right? What is your pain at its best, on your best day? What is your pain at its worst, right? So then I document all of these things so that whatever treatment I give them, that was the baseline. Mrs. Smith, wow, you've really improved in 4 or 5 days, or in a week's time with the therapy and care that I've given you, you've really improved because look, when you first came in, you were a 12. Today, you're a 6. So you are improving. The inflammation's going down. You are feeling better. And you're also functioning better because perhaps I can also ask them about their ADLs. ADL stands for activity of daily living. So, can you dress yourself by yourself? How long can you sit? How long can you stand? How long can you walk, right? So, they have these ADL forms, these activities of daily living that do not have to be created. They're actually already out there, and the patient bubbles them in, and it's something that we can track. So, perhaps they could only stand for 2 minutes at a time, or they couldn't stand by themselves. They needed assistance, or they couldn't put on their shoes by themselves. They needed assistance, or they could only sit for an hour and then the discomfort happens. So they're just great objective forms to help us document a patient in terms of their baseline, how they started out, and are they getting worse or improving? If they're improving, great, we continue with care. If they're getting worse, then we have to come up with other solutions and make the appropriate referrals. Causes of pain are inflammation, infections, ischemia, we've heard these words, tissue necrosis. Stretching of tissues can cause pain. Remember, when you stretch muscles or tendons beyond their anatomical limits, we refer to that as strains with a T. And when we stretch ligaments past their anatomical capabilities, we call that sprains with a P. So strains and sprains are not the same thing. They involve different tissues. So not just stretching tendons and ligaments, but also the joint capsule itself. That could be extremely painful. There are many pain receptors that lie there. Chemicals, we spoke about chemicals, whether it be household chemicals that spill or that you happen to touch or not handle carefully. A lot of these chemicals should be child-proof and out of a child's reach. Burns can cause pain, and muscle spasms, right? Many people have had a muscle spasm in the calf or great toe at night. Very, very uncomfortable and painful. So let's compare somatic pain to visceral pain. If we look at the word soma, it means body, and when we look at the word viscera, it means organ. So somatic pain is pain that's coming from the skin or the cutaneous. Cutaneous means skin. It can come from bone, it can come from muscle, and these are conducted or perceived by sensory fibers, right? Sensory fibers are afferent fibers, AFF, afferent, not efferent, but afferent fibers. Afferent is any bit of information that's taken into the body. It ascends or goes up the spinal cord and ends up someplace in the brain, somewhere in that post-central gyrus of the parietal lobe, right? The post-central gyrus is where all of your sensations are eventually felt. So pain, even though you may prick your great toe or step on something sharp and you say, ouch, my toe hurts, it's really not the toe that's feeling the pain. It's the brain. The brain feels the pain. The finger and the skin just has the receptor for the pain, but it's not truly felt until it ascends all the way up into the brain. That's important. Okay, visceral pain is organ pain. It originates there in the organ, and it is conducted by sympathetic fibers. And the organ pain can be acute or it can be chronic. So here is a picture just to show you that you can feel organ pain in parts that are far away from the organ. If you consider the heart, for example, yes, you can feel pain over the area of the heart, but you can also feel it going down the inside of the arm into the pinky and even the jaw. If we look at lung pain and diaphragm pain, you can have that up at the apex where the lungs are, right? Or at the base of the neck. You can have heart pain also felt in the around the C7, T1 area of the back. Stomach pain can be felt, yeah, where the stomach is, but you can also feel it piercing right through to the mid-thoracic region. You can have a gallbladder attack or gallstones and not just feel it where the liver or the gallbladder is, but you can also feel it just behind that right scapula, which is classical for gallstones. Okay, so a lot of organs can refer pain to different regions, and just because someone is having left shoulder pain doesn't mean they have left shoulder pain. Maybe it's a problem with the spleen. Because they're having pain between the shoulder blades around T3, T4, T5 doesn't mean they're subluxated in their spine or they have a disc herniation or a misalignment. Maybe it's a stomach problem. Okay, so this is why a good thorough exam and a good case history is really important, and a full review of the systems. Okay, what about pain threshold, right? Pain threshold and pain tolerance. So pain threshold is the level of stimulation that's required to elicit a pain response. It usually doesn't vary among individuals, but it can in certain people, right? People who have a low pain threshold, maybe fibromyalgic patients, right, where you could just barely touch a certain spot and they're whimpering. The pain is so intense. So that's someone that has a low pain threshold. And there is a neurological phenomenon with that, and it involves the NMDA receptor. So if you want to take a look at NMDA, N-methyl D-aspartate receptors, you can take a look at that. It has a lot to do with the amount of calcium that rushes into certain cells, and threshold could be met. It involves sodium that rushes in and calcium that rushes in and depolarization, a lot of these terms that reflect back to anatomy and physiology. But it can happen also if you look at the physiology of the NMDA receptor, it needs to have a magnesium plug. So magnesium is that natural calcium channel blocker. So if a person is magnesium deficient and calcium rushes in, they have very, very low threshold. It takes very little to have a response. Okay. In terms of pain tolerance, this is the ability of the person to cope with pain, right? Some people say, oh, he has, he can really tolerate a lot, acting really tough. And then some say he or she has very low tolerance. So some of this could be culturally related. This can vary amongst individuals. So there is a tool that we use. I use this frequently in my office to gauge someone's improvement. So someone can subjectively say they're improving, but if I want to objectify that, objectively measure that, I can use an algometer. And in this particular instance, let's say someone was having wrist pain or forearm pain. I could take this algometer. This is kind of like a lot of tension. There's like a spring in here. And when you push it down, this needle can move and you can measure in pounds of pressure. So let's say you pushed it down and the person had pain at 1.5 pounds of pressure. And then you do a particular treatment, you come back, you document exactly where that was done, the initial time for your baseline. Then you do it again and you're pressing, you're noticing, wow, it's not eliciting a pain response. And then you get to 7 pounds and they go, okay, that hurts right there. And when you move it away, the needle actually stays in that spot, so you can show the patient, wow, you went from 1.5 pounds to 7. This is working, right? If they're constantly at 1.5 pounds and the pain response is being elicited, whatever is being done is not working, okay? That's called an algometer. Nociceptors are pain receptors, right? They are free sensory nerve endings, and they can be stimulated by temperature, chemicals, or even by physical means like pressure. So temperature could be, different extremes, hot or cold. Chemicals, we spoke about acids that can burn the skin, but the nociceptors are also sensitive to bradykinins, which you've heard of before, histamine, which you've heard of already many times, and the PGs, the prostaglandins. Remember, the prostaglandins come from arachidonic acid, and we know that there's different ways of modulating that. Physical means could be pressure. Now we have different types of afferent fibers, or these sensory fibers that can transmit pain impulses. We have a myelinated A delta fiber. Now remember, myelin, the myelin sheath, the purpose of myelin is that it speeds up the conduction of nerve impulses. So the myelinated A delta fibers transmit impulses very rapidly. And these are great at transferring acute type of pain. This is pain that is typically described by a patient as being sharp. It happened all of a sudden, right? It's very localized. They can clearly point and localize where that sharp, sudden pain is coming from. Unlike the unmyelinated C fibers, these transmit impulses slowly because these are unmyelinated C fibers. These are referring pain that are chronic opposed to acute. The chronic pain is usually described as dull compared to sharp. It's diffuse. It's achy, right? It's not sharp, stabbing, sudden pain. So the myelinated A delta fibers and the unmyelinated C fibers are different in terms of the speed of how they transmit the impulses. Also, one is acute versus chronic. One is sharp and sudden. The other is diffuse and dull. Now, dermatomes are an area of skin that's innervated by a specific spinal nerve. And you learned this back in anatomy and physiology. It is a mapping. And I'll show you an illustration in case you have forgotten it. Most have learned it by looking at an individual in the anatomical position and really had trouble making sense of the whole C5, C6, C7, C8, T1 dermatomes, or for the lower extremity, the L1 to S1 dermatomes. However, when I teach it, I like to show it in a quadruped position. Okay, and I think it may make some more sense looking at it from that perspective. So let me just go here and show you that if we start here, right, on all fours, you can see, okay, here's C2, C3, C4, 5, 6, 7, right, C8, then you got T1, T2, 3, 4, all the way down to T12, and you can see the L1 to L5. It really moves in order all the way to S1. So it helps us differentiate based on the abnormal sensations or even pain levels, the pain distribution, if it's coming from certain levels of the spinal cord. Now there's reflex responses as well. This is when a patient has these involuntary muscle contractions that move the body away from the pain source, right? This can happen in response, like a flexor reflex, right? You touch something that's sharp or hot with your hand, and then quickly it withdraws. Or you step on something sharp or hot with your foot, and you have the crossed extensor reflex, in which, let's say you touch something hot with your right foot withdraws, which is the flexor reflex, but the same information crosses over to the other side of the body to extend the left leg with the quadriceps so that you maintain your balance. Okay, so that's called a crossed extensor. Reflexes. Think about if someone's going to punch you in the stomach. Don't the muscles tighten up reflexively in response to pain? If someone has appendicitis, the muscles may be guarding of the abdominal region. If someone is dealing with a vascular injury of the vertebral arteries, if they're in the process of stroking, the neck becomes very tight and very stiff. There have been many patients that have come to physical therapists or doctors of chiropractic with stiff necks, and it doesn't always mean that they have a disc herniation or muscle spasms that are purely musculoskeletal in origin. But if there's an injury to the carotid arteries or the vertebral arteries in the neck where they're just moments away or days away or hours away from that artery rupturing, the neck doesn't want to rotate or to turn or to move, so the person is complaining of stiff neck and headache. Okay, and that's due to the underlying vascular injury that is taking place. So it's an involuntary muscle contraction to guard against movement, again, a protective mechanism. If someone has a disc that's herniated and there's pressure on the spinal cord or pressure on the nerve, they're going to have lower back spasming. That is to prevent further damage to their spinal cord or to the nerve. So taking a muscle relaxer can be helpful in some instances, but it can be extremely hurtful in the others. I advise that if a patient is taking a muscle relaxer or an analgesic or pain medication, and then they can move so much easily, I still advise them not to, because they're going to do further damage to what was already pre-existing. But if they're using it just to break the spasm to get more comfortable, and they still are extremely careful, that's where they are the most beneficial. So here's a patient who has a lumbar disc herniation, right? So this is just an adjusting table here, a chiropractic table, but here's an individual who has what is referred to as an antalgic lean. This is not consciously controlled. They're not leaning this way on purpose. Their body is doing this reflexively to take the pinch away from their spinal cord and away from the disc and the nerves, okay? And when that disc and nerve heals, they will stand perfectly erect and straight, which will be the indicator that they are healing up, okay? But as long as they have this reflexive spasming, we know the problem is still there, the inflammation is still there, and the cause of the problem is still there. The spinothalamic bundle, right? You remember this from neurology, the spinothalamic tract, the lateral spinothalamic tract, the anterior, right? These were all, when you look at the term spinothalamic, this tells us that the information is going up the spine and ending somewhere in the thalamus. So this is a sensory or an ascending or an afferent tract. It's carrying sensory information. The neospinothalamic tract, which carries type A delta fibers, these transmit the very fast impulses. Remember, the myelinated fibers. This is for acute pain. The paliospinothalamic tract is the type C fibers. These are the slowly transmitted. They're unmyelinated fibers, remember, for chronic pain, the dull pain. The spinothalamic tracts are going to communicate with other regions of the brain to integrate the appropriate response. One of the areas that it refers the information to is the RAS, the reticular activating system. And this RAS is located in the midbrain, where you have the medulla and the pons. It's the awareness of the incoming brain stimulation, okay? The sensory information coming in. The other part of the brain that is going to be stimulated is in the parietal lobe. It is the somatic sensory area in the cerebral cortex, also called the post-central gyrus. It allows the person to perceive and localize where the sensation of pain is. The other areas that are involved in the pain pathway is the hypothalamus, which gives us a visceral reaction, maybe faster heart rate and pulse rate and breathing. It affects our blood pressure for sure, but also the limbic system, which is the emotional brain. So here, if we look at this picture here of the brain, here's the left hemisphere of the brain and the right hemisphere of the brain. This is the frontal lobe, and back here is the occipital lobe. This is the frontal lobe, including the red area. This is the precentral gyrus, where just behind it in the parietal lobe is the postcentral gyrus. So the precentral gyrus, which is part of the frontal lobe, is where the motor cortex is. This is where the initiation of all voluntary muscle movements take place. But all of the sensory input, after it's relayed to the thalamus, ends up its final destination after the thalamus. It's going to relay it up here into the postcentral gyrus, which is the sensory cortex. And if we look on the sensory cortex side here in the blue, we'll see that it represents all the body parts, right? And this is what I mean when I say pain is felt in the brain, right? So if we go here and we stimulate this part of the brain with an electrical impulse, the person will tell you they feel it in the finger. If we come here and we stimulate this part of the brain, they'll tell you they feel it on their lips. If we come and we stimulate this part of the brain, they'll say, oh, my tongue is tingly. That's a weird feeling, right? And then if we go to the motor side and we deliver electrical currents here, we'll start to see the fingers move, okay? So hopefully that puts it in perspective. This is referred to as the homunculus. You probably remember that back from the neurology lecture of A&P. So let's take a look at the pathway from the point of, number one, stimulation, and follow it all the way up to that somatosensory area, which is the parietal lobe right here, where the postcentral gyrus is. So we have some sort of stimulus. It looks like a sharp nail that's hitting the skin, and that's where the pain receptor lies. That's the nociceptor. So it's going to relay that information through a peripheral nerve, which is the afferent pain fiber. It's going to go into the spinal nerve. Remember, the spinal nerve is a mixed nerve because there's a sensory and a motor component to it, so it's a mixed nerve. So the afferent information is going to go in through the dorsal root, right? We have a dorsal root ganglia right here, because it's going to continue to ascend into the dorsal root, where it finally enters the dorsal horn, right? The gray matter is here. There's a dorsal horn and a ventral horn. The sensory input is going to synapse right here at the dorsal horn. It's going to relay that information. It's going to decussate, right? Deca, like Roman numeral 10, deca, the X for the cross. It's going to cross over to the other side. It's going to cross over to the other side. The lateral spinal thalamic tract is going to carry pain. It's going to ascend up. It'll synapse, right? It's going to make its connections to the pons and the medulla, that part of the midbrain. We have the reticular activating system. And it will also relay that information to the thalamus. The thalamus is the primary sensory relay for all the sensory input into the body, except for the sense of smell, right? All sensory input is relayed to the thalamus, and then the thalamus is going to relay it to a major part of the brain called the parietal lobe. That's where the postcentral gyrus is for sensory input. It will also relay it to the emotional brain, the limbic system, and it will also relay it to the hypothalamus. Remember, the hypothalamus is what oversees and controls the autonomic neural system. And the autonomic neural system is composed of the sympathetic and the parasympathetic. So this is where you have these visceral changes that take place, right? Increased heart rate with pain, increased breathing with pain, all right? So keep this in mind. Again, pain coming in, the nociceptor gets stimulated, the sensory information moves up the peripheral nerve, which is an afferent sensory nerve, comes into the dorsal root, all sensory, 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 synapses at the dorsal horn. The dorsal horn is gray matter, it's unmyelinated. It crosses over, right? This is why the right side of the brain perceives information from the left side of the body, and it's why the left side of the brain controls movement on the right side of the body, right? It crosses over. This is why when someone has a stroke on the right side of the brain, the left side of the body becomes paralyzed. All right, so it comes up the lateral spinal thalamic tract, it synapses in the medulla and the pons. It crosses over to the other side of the brain, right? We know that. The thalamus gets information and relays it to the postcentral gyrus, hypothalamus, and limbic system. Now let's talk about the gate control theory. The gate control theory is this built-in system that can help regulate the pain. So it can modify the pain stimulation. And there are different ways that we can modify and kind of trick the system, right? We've always seen if someone was hurt during a sporting event. Well, even let's take it a little bit earlier than that. Think of what happens if a child bangs their hand or their wrist, and they come over crying, "Mommy, Daddy, it hurts," and then you go, "Oh, just shake it off." You shake the hand or you rub it, and they feel better. Okay, because there's a cortical distraction that's taking place. So we can modify the transmission into the spinal cord and the brain by using motion, using vibration, even using ice. These are different things that can modify the pain stimulus conduction and transmission into the spinal cord and brain. Now, when the gates are open, then the person's going to experience lots of pain. And when the gate is closed, it'll reduce or modify the passage of pain impulses into the brain. So let's take a look at this gate. So here we have some sort of painful stimulus coming in. You have the nociceptor, which is the receptor. It's going to carry the pain signal either through the A delta fiber, which is for the acute pain. We know it's myelinated, or the C pain fiber for more chronic pain. It's unmyelinated. And that information is going to come in. And in the spinal cord here, there's going to be the release of substance P. Substance P, they say the P, some say it's for substance pain. Some refer to it as substance preparation, substance powder, even though it's not a powder. But for most people, they think it's P for pain. It just helps them make the connection, but it's really preparation or powder. And so the substance P is going to then send this painful information up the lateral spinal thalamic tract, right? It's going to continue coming up here. The painful stimulation is going to go up to the brain in that medulla and the pons so that the reticular activating system is alerted. And it's going to come up and it's going to relay to the postcentral gyrus. It's going to relay to the limbic system and to the hypothalamus. Now, wouldn't it be great if there was a way to modulate and to kind of create a blockage somewhere in here, either at the interneuron or at the substance P, or even right here, right? If we can somehow create a blockage here, then the signals never make it up to the brain. Well, let's take a look. It just so happens that we can influence the gate and we can close the gate. So how do we do that? Here we have the painful stimulus coming in. It's moving up the afferent fiber. And right here, we can have enkephalons. Enkephalons act as like morphine, okay? Now, how does this happen? Because the interneuron can be activated by these afferent touch A beta thick fibers. So we have input coming in. Maybe it's touch, maybe it's vibration, maybe it's the information from a TENS unit, right? Maybe it's ice that's coming into the area for that sensation. But it comes in and it can stimulate this interneuron. And the interneuron can release these enkephalons, right? These are like opiate-like structures or chemical mediators. So we can block the signal here at the afferent fiber. The interneuron is releasing enkephalons, right? The opiate receptors are blocked by these enkephalons. Some of these enkephalons are just released here by the brain, and it's going to push it down, also stimulating the interneuron. And again, whatever the interneuron releases is going to block here. It's going to come out here and block the connection at the interneuron, right? Because remember, you have this sensory neuron coming in, and it has to synapse at this interneuron before it crosses over. So if you can block it right there, beautiful. So you have this sensory information, this distraction coming in, whether it's ice, vibration, the TENS unit. It comes in and it's going to affect the interneuron. The interneuron is going to release the enkephalons. It's going to release substance P, right? It's going to block the release of substance P, because substance P enhances the pain perception. So we want to block it, okay? So you got sensory input coming in. It's painful information, but we have the distraction coming in through this fiber. The interneuron is going to release the enkephalons. It's going to block right here the afferent fiber, right? The interneuron is going to release that and block it. At the same point in time, endogenously from the brain, it's going to release these enkephalons. The enkephalons come down this way. It too motivates the interneuron to even release more enkephalons. Okay? When this happens, the substance P is blocked. So the signals don't make it up to the brain because the gates are closed. Does that make sense? Painful information coming in, but so is the vibration, the ice, the TENS unit, the cortical distraction. You have two things that are going to stimulate the interneuron. One is all that information coming in, and the second is the brain itself. The brain itself can send information to the interneuron. When the interneuron releases the enkephalons, these opiate-like structures, it's going to block the connection between the pain fiber and the ascending information up into the brain, right? Substance P cannot be released. It can't be released if it's not gaining that information, all right? So the gate is closed. So we spoke a little bit about the application of ice. Ice slows down the opening of the sodium channels, right? In order for information to make it up to the brain, we have to have depolarization that takes place. In order for depolarization to take place, sodium channels have to open. So ice slows the rate at which sodium channels open, so people will still feel pain, but perhaps not the same intensity. That's why ice seems to help, along with the cortical distraction. There's transcutaneous electrical nerve stimulation, or the TENS unit. This is going to increase the sensory stimulation at the site, and it's going to block the pain transmission up to the brain. We spoke about the opiate-like chemicals, the opioids. We spoke about the enkephalons, right? Those are opiate-like chemicals. And they're secreted by the interneurons, and that could be stimulated by the brain. That's the endogenous secretion of it. Okay, it's going to block the conduction of the impulses to the CNS. The CNS is the central neural system, the brain and the spinal cord. Okay, that's a good place to take a break if you'd like before we go on further. If your energy is good and you want to keep on going, then let's go. So we're talking about the manifestations of pain and the diagnosis of pain. So when a patient comes in and they say, oh, my hip hurts, I like for them to point to where it is, because everyone can have a different understanding of what the hip is. Maybe for person one, the hip is right in front of their thigh. For some people, the hip is on the lateral side of the thigh. And for many people, their hip could be the back side of their lower back. So I like for them to show me and point to exactly where it's uncomfortable, and I make the appropriate documentation of that. And on my initial intake form, I actually have a picture of anatomical person from the front and the back, and they can mark it up. And there's different scales that they can use. Is it sharp? Is it dull? Is it pins and needles? Because I want to have a good documentation of what they're indicating is their problem. So location, where is it? The other questions I like to ask revolve around OPQRST, right? It's a little mnemonic, OPQRST. O is for onset. When did this happen? What were you doing when it happened? That's for the O. For the P is like, what provokes it? What makes it worse? Or palliative, what do you do that makes it better? Q, the quality of the pain. Can you describe the quality? Is it aching? Is it burning? Is it sharp? Is it throbbing? Right? If it's like burning, then it tells me, or sharp and burning, that it's something neurological. If it's throbbing, maybe it tells me it's vascular. If it's deep, maybe it's deep in the bone. Okay? So also for the quality, does it... besides the burning and the sharp and the throbbing, it helps us try and determine, is it more acute or is it chronic, right? Okay, OPQR, does it radiate or refer, right? Is it just stay in that area? Do you feel it travel anywhere? That's the R. The S is for site and severity, right? Show me again, point to it with your finger, that's the site, and severity on a scale of 1 to 10. And remember the pain visual analog scale that we used earlier. And then T is for timing. When did it start? And how long does it last? And what triggers it? Is it morning? Is it afternoon? Is it night? How long does it last for, right? All of this gives us great information. So OPQRST, something good to review. The signs and symptoms and the diagnosis of pain. So there are some signs like pallor. Does the person look like something's not right? They're really in a lot of pain. Do they look pale? Are they sweating, which is diaphoresis? What about blood pressure? Right? When the patient comes in, I can take their blood pressure. And I just don't take it once. I take it twice, and in both extremities, both arms, left and right. And I document it. I document it, and then I take an average of it. Sometimes I'll do 3. So with high blood pressure, pain can create high blood pressure. Tachycardia. I want to feel their heart rate. Is their pulse rate quick? Do they feel nauseous? Is there vomiting? This can certainly happen with acute pain. Do they feel lightheaded, dizzy, or are they going to faint from acute pain? I've seen this happen many times in my office. Someone has to bring them in. Anxiety. They frequently have fear or they're anxious. This is very, very common, especially with chest pain or angina pectoris. It happens a lot with hypoxia, right? When there's decreased blood supply to the brain, you have to remember the brain isn't getting enough oxygen or glucose. And the neurology doesn't like that. And it will make you aware of it through anxiety and fear. So oftentimes I could just put on a pulse oximeter, check their pulse rate, and I could check the oxygen saturation. Okay. Clench fists, right? If they're in pain, they're making a fist, which is almost descriptive of spasming. Are they restless? Are they constantly shaking their leg? Are they constantly moving? Are they guarding an area to prevent stimulation of these receptors? And we can look at young children and pain because a lot of young kids have trouble explaining discomfort or pain. But usually kids don't lie, right? They don't make up these things. It's very rare that a 4-year-old or a 3-year-old is going to point to their hip and cry and say it hurts, right? And you never ever take lightly a child that complains of pain, especially hip pain. That's a pretty serious injury right there. So, how do infants respond physiologically? You're going to feel tachycardia. There's going to be increased blood pressure. You could look at their facial expressions. These are things that you're evaluating, and they don't even know that you're evaluating them. One of the other things I do, not just with kids, as kids get older, maybe they could make up stories. Maybe they want to get out of school. Maybe they don't want to go. Maybe they have anxiety about something, so they'll say that something hurts when it really doesn't. What I do is I could just feel their pulse, and then the area that they say hurts, I touch it, and I try and irritate it, because if it really does hurt, you're going to see an increase in their pulse rate. But everyone has different coping mechanisms to deal with the pain. There's a variety of behaviors, but some of them do have difficulty in trying to describe it. So you have to really be a good listener and pay attention. Some kids will simply just withdraw. They'll close the door, go in their room. They don't want to socialize. They don't want to communicate with anyone. So you have to be aware of all of these signs. There is a such thing as referred pain, which means that the perceived site of pain is distant from the actual source. And one of the best analogies I tell my patients is when you step on a dog's tail by accident, it barks at the mouth. Even though the tail hurts, they're expressing it someplace distant to that area. Okay, so keep that in mind. Someone can have finger pain and it has nothing to do with the fingers. It can come from the neck. If you think of a heart attack is a problem with the heart due to lack of blood supply or ischemia, but where are they going to experience it? Sometimes they'll make the clenched fist and hold it to their chest as an indicator, but oftentimes they experience pain in the jaw first or down the arm. They're constantly shaking out their left hand. Here's just another diagram similar to the one we showed earlier about referred pain, the different organs that can refer pain to distal areas. Phantom pain is something we hear of frequently, typically following an amputation, where they experience pain or tingling even though the body part isn't there. The phenomenon is not fully understood, but I think the rationale is pretty easy to understand. I think it makes sense. Think of it this way. Close your eyes for a second. Close your eyes and think of a yellow banana. Now, in your mind's eye, with your eyes closed, you can actually see a yellow banana. Why is that? Because you've had that experience before. You know what yellow is, you know what a banana is. If I say think of an elephant with your eyes closed, you can see a big gray elephant because you've taken that in. That data and memory is already imprinted upon your brain. So phantom pain, I have a patient, I spoke about him in one of my earlier videos about when he had that redness in his lower leg and he was a diabetic and didn't know his blood sugar was over 500 to 600, they amputated his great toe. And we speak about it frequently, and he tells me that he still feels feeling there and he has sensations. Sometimes he says it's itchy and he knows that there's no toe there. How can that be? Think back to the homunculus. Look back at that post-central gyrus, right? The information and feelings are imprinted in that post-central gyrus. So all the nerve endings proximal to where that toe is still there. Just the distal part is gone, but the rest of the ascending pathway up into the brain still exists. Pain tolerance, the degree of pain or intensity or duration that could be tolerated before the breaking point, before the person takes action. I have many patients that come and I'll say, how long have you been dealing with this? And some people say, it happened this morning. I got right here, right? Some people say, 2 to 3 weeks, right? They've been tolerating it and then they just couldn't take it anymore. It may be increased by the endorphin released. It may be reduced because of the fatigue or the stress. When I say may be increased, I'm not talking about their pain may be increased. Their tolerance may be increased to the pain because of the endorphin released. It may be reduced because of fatigue or stress, right? Some people just get tired. Pain perception is subjective, but you can compare it when you start using that pain, the visual analog scale. The classification, let's look at acute pain. Remember, acute is sudden and severe. It's also short term. It decreases, right? Once the condition has been treated, the acute pain goes away. When the acute pain is not treated and becomes chronic, then we have long-term issues. Acute pain is usually very well localized. It's generalized. There could be increased blood pressure, increased heart rate. The skin will be cooler and pale. They could be moist skin as well. There could be increased respiratory rate, right? That sympathetic response. Just think of what the sympathetics do. Increased skeletal muscle tension to be a splint to protect that area. They can feel nauseous. The vomiting may occur. They can have a strong emotional response. They could be anxious and fearful. When you compare it to chronic pain, this occurs over an extended period of time. And it's usually more difficult to treat than acute pain, right? The longer they've had it, the longer it takes to take care of it. The shorter they've had it, then the quicker it is to help them resolve. It's a little bit difficult to localize the pain with chronic pain. The individual will be tired, they'll be fatigued, they'll be irritable, and even depressed. That's why chronic pain can lead to depression, and that only exacerbates their condition. The pain may become their primary focus in a patient's life. There are people that we refer to as enterpainers. Not entertainers, enterpainers, where their pain becomes the story of their life. Whenever they're over for Thanksgiving, whenever they're over for Christmas or the holidays or any type of family gathering, that family member or friend, that may be the only thing that they discuss. It becomes the centered thing around their life. And then sleep will often become disturbed. And if they don't sleep, then it's difficult for them to heal. Their appetite may also become affected. It can either result in weight gain or weight loss. It can develop depression, loss of hope, anger. Frequently, it will affect their ADLs, right? The ADLs are the activities of daily living, so it's important to gauge and monitor that, not just to in terms of chiropractic, physical therapy, occupational therapy, not just in terms of how to initiate the treatment plan, but also to gauge as an outcome assessment, is what you're doing working? All right, let's move on to headaches, right? Because this is still pain. People are still uncomfortable with headaches. Sometimes the person can have a sinus headache, right? They can just nasal congestion, sinus congestion, or they can even develop a headache from eye strain. It could be an indicator with young kids if they're getting headaches, just to simply get their eyes checked. There could be muscle spasm that can cause headaches. We call these tension headaches. It can happen from emotional stress. Just think about the most important organ being the brain and the upper trapezius. The upper trapezius shrugs the shoulders up. So if you were to hear a loud explosion or a loud bang, think of what you reflexively do. The shoulders come up and the hands come up to protect the head, right? It's a reflex. You don't even have to think about it. So when that's from the hearing that sound. But emotional stress, people often get um, spasming and tension and trigger points along the upper trapezius because it's always contracting in spasm and tension to protect the brain. There could be pain that's felt in the temporal headaches on the sides as a result of dysfunction to the TMJ, temporal mandibular joint dysfunction. There could be migraine headaches. These are when there's an abnormal blood flow and metabolism in the brain. So migraines do have this vascular component to it. Intracranial headaches, anything that's putting increased pressure inside the skull. There's central pain that's caused by dysfunction or damage to the brain or the spinal cord. That's central pain. There's neuropathic pain, which involves more of the peripheral neural system, right? Central pain is the CNS. It's the brain and spinal cord. Neuropathic pain is caused by trauma or disease involving the peripheral neural system. That's cranial nerves, that is spinal nerves. Think of the sciatic nerve being irritated. If someone has a vertebral subluxation, a misalignment of L5, or a pelvic tilt, or a piriformis that's in spasm, that can irritate the sciatic nerve, giving sciatica. Ischemic pain. This results from a sudden loss of blood flow to an organ or to a tissue. Okay, and cancer-related pain, right? That could be caused by advances of the disease. The pain is associated with treatment resulting from coexisting disease. The pain management. All right, what do we do? Well, a lot of people use analgesic medications. They can take analgesics orally, parenterally, like they can inject it. Transdermally, they do have patches, or they do have creams that can be applied to the skin. Remember, the skin is permeable. So whatever's on the skin can diffuse into the deeper tissues, even into circulation. We know that because think of nicotine patches, think of motion sickness patches, and these transdermal patches work the same way. And they're classified and they're determined based on the ability to relieve the pain. Does the person have mild pain, moderate pain, or severe pain? So for mild pain, we can use aspirin, acetylsalicylic acid, acetaminophen, NSAIDs. And this tells you, the actions. It's going to decrease pain at the peripheral site. But the problem with them is when they're used for prolonged periods of time, the person can develop gastric ulcers or bleeding. So you have to be really careful with that. For moderate pain, sometimes they use Percocet or Vicodin or codeine. These act on the CNS, the central neural system, as well as affecting their perception of the pain. These are narcotics, and high doses can actually be dangerous, and they can depress respiration. If you depress respiration, then you can decrease the amount of oxygen into the system. Decreased oxygen, decreased ATP, decreased sodium-potassium pump, decreased healing time. For severe pain, they'll use morphine and Demerol and oxycodone. These also act on the central neural system. They give this feeling of euphoria. They help to sedate the patient. But these are narcotics, right? So these can become very addicting. High doses of these can not only depress respiration, but they can actually cause constipation, which becomes a real major problem for people, commonly after surgery. Post-surgery could be very, very painful, so people can use these oxycodones, and it will lead to constipation, so then it results in using laxatives. And sometimes people will use a combination of these drugs, okay? But we have to be real careful. We are we know that there is an epidemic of oxycodone overuse. And to try and prevent that, there is a huge movement that the government is pushing towards manual medicine and physical medicine. What we mean by that is primarily using a non-chemical, non-invasive, safe and effective approach first, which includes chiropractic care, it includes physical therapy, and includes occupational therapy as well. Pain management, still people use sedatives and anti-anxiety drugs. These are the adjuvants to the analgesic therapy that we mentioned before, because it helps to promote rest and relaxation. And it can reduce the dosage and the requirements for the analgesics that we discussed before. Chronic and increasing pain, this is where the narcotics come into play. They may occur with cancer. Just have to really gauge that over time, because the tolerance to the narcotics develop over time, which means that you may need increased dosage for them. And this is why they're always coming out with different treatments and new drugs, because of the tolerance that people have developed to them. Right? Similar concept with the overuse of antibiotics. Something very basic may not work, and then the strain changes into a superbug, and then they use something stronger. And then if they overuse that, then they have to use something even stronger than that. Severe pain is, for that, the patient has to administer the medication as needed. There's something called PCA, which is patient-controlled analgesia, right? You see patients in a hospital, and they have this little button, and when the pain becomes super severe, they press the button, and it releases more of that medication as needed. Intractable pain, this means that it just cannot be controlled with medication. This is when other more invasive procedures have to be utilized, or surgical intervention becomes a choice. There's a procedure called a rhizotomy, and this is a surgical procedure that severs the nerve root so that there's no ascending input that makes it to the postcentral gyrus. There's a chordotomy, which is a surgical procedure to disable the pain tracts, right? That's in the actual spinal cord. And then there's injections, like epidurals, right? So local anesthesia is something that's injected locally or applied to the skin or the mucous membrane. That's local. You are completely aware and conscious for that. Spinal or regional anesthesia is going to block pain from the legs or the abdomen. That would be like an epidural, right? This is what many women get during labor, but they can't feel their lower legs, right? They have to be told when to push. General anesthesia causes loss of consciousness, right? This is either injection or breathing in nitric oxide or gas, and it just, knocks you out. That's a general anesthesia. Neurolept anesthesia, right? That's a tricky word. Is the type of anesthesia where the patient can respond to commands, right? They can't necessarily feel anything, but they can hear, and if the doctor says, can you move your right leg, then you can, all right? You can respond. The patient is unaware of the procedure. They do not feel any pain or discomfort with that. So again, here is the local anesthetic like lidocaine or Novocaine, right? It's injected locally. It's like if you go to the dentist and you have a filling and they inject that, it's going to block the nerve conduction in a peripheral nerve, right? Used for a tooth extraction. General anesthesia, this is intravenous. It affects the brain, so there can be a partial or a total loss of consciousness. This is used for general surgery. There's no pain awareness when it's combined with an analgesic. And then we have the relative or neurolept anesthesia like diazepam. This is where you can respond. The spinal anesthesia, this is where the local anesthetic is injected to like an epidural. It's going to block the nerve conduction below the area of the injection, right? This is surgery being done to the lower part of the body, labor, hip replacements, things of that nature.